I don't know about you all, but when Stuart went out into the audience with a microphone, I had a moment of panic. He was from A&M. I thought he was going to start leading us in those weird yell chants. But I'm glad he didn't. Good morning. My name is Justin Spooner. I work with Greystone. I'm joined this morning by Melissa Heiss from our sales and marketing group. We're going to be kind of drilling down, like Stuart said, on kind of the theme from yesterday, the aging in place and what that means for the operations of our communities. I think it's really important to understand, I'm certainly not an expert in home and community-based services. As an operator, I've worked alongside some complementary services, but I think it's important to understand Melissa's background and recent experience in that world.
I'm Melissa Heiss. Many moons ago, I had the privilege and honor of opening a Greystone developed community with Justin Spooner, and so we're kind of having a full circle moment today on the stage together. But for the past 8 years, what I've been doing is developing and operating hospice companies in the private equity sector. And what we did, part of our strategic plan, was to work with senior living communities like you. So that way we could have our goals and we could develop these companies, but partner and develop a product that was a little bit different but provided quality care. So we're going to talk about that a little bit today.
Awesome. So as we get started, as organizations that operate communities, you're in the HCBS business, whether actively or passively. So, one of our goals is to talk about how you can manage it and not it manage you. So we're going to talk a little bit about that today. So some things we'd like to accomplish in no particular order as we go through our talk today. Understanding the trends in the HCBS world. It is a giant market. We're going to talk a little bit about that. And you are, as organizations, a big part of their strategic planning to grow that market.
We're also going to learn how integrating home and community-based services helps your overall revenue, and it can increase your revenue by bed management and some other best practices.
As we kind of go through some of the questions, some of the strategic questions to ask yourself as you're rethinking your strategy with HCBS, just some best practices, some risk mitigation, some ways to integrate and communicate with those third parties.
We're also going to review the pros and cons of in-house versus third party and what those risks and pros and cons are for your community and your organization.
And finally, just some strategic considerations. Many of you may already operate some HCBS services in your organization, or you go third party, but it's always worth going back and thinking about it, rethinking that as you look at your strategic plan and how that relates to your mission. So HCBS is a pretty broad topic. There is a lot of different areas where HCBS touches the continuum of senior living services. You all have seen this picture probably every year for the past 10 years in senior living, but we wanted to define kind of when we say HCBS, what are we talking about today? And then as we wrap up at the end, we'll talk about maybe how we should change our thinking about what that is and what's included. But those areas that really kind of span the continuum, you're going to hear a lot today about case management. A lot of you probably already do that or have somebody in your organization that does that role. And that's a really important piece to managing the continuum in your community, whether you're a standalone assisted living, memory care, or whether you're a full CCRC. Being able to integrate and stay with those residents as they move through your continuum and manage that continuum is a theme that really should go throughout this continuum. A big trend, and we're seeing a lot more of it, is visiting physicians and nurse practitioners. We're even seeing a lot of these standalone IL, AL memory cares, while they're not required to, having a medical director, having them involved in the case management and the continuum management of those residents. A lot of you participate in adult day services, so that's certainly part of that HCBS continuum. And of course, home health care. When we say home health care, we're largely talking about the reimbursable Medicare-based home health care services, but there's also private duty. And of course, as Melissa shared, hospice as he kind of rounds out that continuum of HCBS.
So those of us in senior living and healthcare, it's second nature for us to know about things that are happening with aging parents, what home health and different services. We might not know all the specifics of it, but we know enough that when our parents or our family members need assistance, we can guide them. But the general public really doesn't. So as to John's points yesterday, we had the crashers, and the crashers come in and we see them all in our sales centers, we see them in our healthcare centers. And what happens is it's a 911 immediate. So we're having a lot of culture now. We're starting to see, Bradley Cooper's doing a documentary. We've had Still Alice. I know James Seymour has a movie out where we're trying to drive information to the public to make it aware of what we actually do. And I think that it's really important for us to be able to see that. So I do want to shine a light a little bit on Jimmy Carter, because since I've been doing hospice the past 8 years, hospice is a little bit of a scary word, but former President Jimmy Carter is shining a light on quality of life for some of these home care-based services. And I think it's important for us to talk about that in all aspects of our community, not just our healthcare sides of the community, but for our independent living sides as well. Because yesterday, that was a hot topic of aging in place in the home, and what can we provide in the home, but what can we also do in our communities here as we develop those.
So we're going to talk a little bit about some market trends in HCBS. But we thought this was something interesting to look at in light of some of the different constraints that we have in operations. The biggest demand for home health services, HCBS, is obviously nursing care. You can see it's the lion's share of the demand, which calls the question: how are we going to continue staffing nurses in our communities, as well as meet the need in the HCBS world? So what's interesting though is you look at this graph. We've seen significant growth, particularly in the physician care, as well as the medical social services. That's a really expanding area of HCBS, and some of those things you already do today, but it is a growing need and a need that you're already meeting, so we need to be taking credit for that. The last thing I'll say is the expansive growth in HCBS really was accelerated by the pandemic. Obviously, we had to have people coming into the house, but also the expansion of telehealth. And we've all been to the Greystone event, the Ziegler events, and 10 years ago we were talking about the pending explosion of telehealth. Well, the pandemic really expanded that and exploded that, and it allowed HCBS companies to grow exponentially and be more efficient with how they deliver those services.
So we're going to talk a little bit about the home health sector, and I mean the Medicare certified home health sector. Yesterday, John in his presentation talked about how everybody is hoping to possibly, a large population, 50% is wanting to live to 100. So what does that mean for us in our communities? Well, if you'll look at the home health care market, we were at $153 billion in 2023, but look at 2032, it's going up to almost $280 million. So that means that people are needing more nursing care in the home, whether that's wound care, whether that's any type of chronic management for healthcare reasons, but they're also using therapies as well, so occupational, physical, and speech, again, for that aging in place model. But what does that mean for us in our community? So what we have at the National Council of Aging is that approximately 95% of adults age 60 and over have at least one chronic condition, while 80% have 2 or more. So if they have 2 or more, what does that mean for our new communities that we're developing and the ones that are already open? We have a higher acuity resident. And so when we have a higher acuity resident already coming into independent living with 2 chronic conditions, how do we manage them and age them in place in our own community? We want them to move into our community and age in place with us. So what's that happening? What we need to do is find really good partners for home health so we can have them age in place and be able to manage that and lower the rehospitalizations and keep them independent longer and healthier.
Want to talk a little bit, take a quick aside. This is more of an anecdotal trend, but one that's happening in all of our communities every day, every interaction with residents, and especially with adult children. We sell our communities, regardless of the level of living that you provide, as a one-stop shop experience. And that's a great thing, and we should. But we need to start to think about how we present that information. And so when we think about external influences that experiences you may have had that are one-stop shop. What are some brands that come to mind? Those of you who are my age and maybe a little more experienced remember the Sears Roebuck catalog, which was great. You could get your house, you could get your car, you could get your waffle maker all delivered from the catalog. Do we really want to compare ourselves to that? Probably not. So that's a bad one. A little more common for today is Amazon. You can get your pancake maker, your pencils, and your paper, and a treadmill delivered the same day. All great things, But again, that one-stop shop expectation, it starts to really ask the question, do we want to compare? I can't do a presentation without putting buttons up there. And this one really hurts me because it's a vast panacea of great things. So you can get brisket, you can get deer corn, you can get your pellet grill all while you're filling up your gas and sugaring up your kids and buying beef jerky. But again, is that what we want to compare ourselves to in senior living? Probably not. So a few years ago, during a presentation, someone told me that, hey, our CCRCs and our communities are more like a bespoke experience. We understanding the needs, asking the questions, and I have to be really honest with you guys, I didn't know what bespoke meant. So I went to the interwebs and I found the definition of bespoke. And it came from the internet, so it must be true. We all know that's not right. But doesn't this fit more of what we try to do when we sit down with a resident, when we sit down with an adult child? We're asking them questions, we're understanding their needs. We're not throwing everything at them that we do, because that would probably just paralyze them. So we have to sit down with them, talk about their needs, and then lay out a plan for how we can help them get to the next step and reassure them that the services we provide and also the services we can extend through partnering with HCBS can help meet that one-stop shop expectation that gets created in their mind.
So we're going to talk about the hospice market for a minute. So I typically get 2 reactions for the past 8 years of what do you do for a living? And I say, oh, I'm in hospice. And the person is, oh, great, I had a great experience with hospice. And the other one is like, oh, I'm so sorry. And what they don't realize is that there's many things that not just for the individual consumer, but for our residents that hospice can help us do. So I want to highlight a little bit that the NHPCO, which is the National Hospice and Palliative Care Association, did a study, and patients on hospice live an average of 29 days longer. And not just longer, but quality. And when you add the quality aspect, isn't that really what we do? We want our residents to live longer lives. We want them to be healthier. We want them to have quality. And we want to be the one-stop shop, just as the adult children and the residents expect when we move in. So how do we do that? Well, look at the hospice market right now. If you'll look at the demographic, you have almost 64 million in Medicare enrollees. But look at how many people actually use hospice. Under 3 million. Look at the utilization there. What most people don't know, and even in our own communities, we typically, I know I've had this conversation with many of our partners here, is they think hospice comes in the last week, the last 2 days. But really, we have a 6-month window, and Jimmy Carter showed us that we can actually be on hospice a little bit longer, up to a year. What does that provide for our families? Not only does it provide additional care, additional staffing, but it also provides medical equipment that Medicare pays for, supplies that families have been coming out of pocket for, and medications that hospice covers when it's time for that diagnosis. So isn't that an added value along with home health services that we should be talking about and working with our communities? But also, what does that really mean for us as well? If we have a new community or a memory care and we have 50% on hospice, how do we manage our beds and manage our revenue there? Are we having those conversations of, okay, sales and marketing, yes, memory care is full, but don't forget 50% of our residents right now are currently on hospice. So how do we plan and prepare for that?
All right, so we're going to switch gears a little bit and start talking about some questions as organizations you should ask yourself, as well as some best practices to consider. You all probably have had these conversations, but it's also good to have them again as the world starts to change. So as you start to look at your strategic plan and all the different elements that are part of that, how do these complementary services fit into your plan? And some questions you might want to ask yourself is, where are the gaps? What services would complement our mission? Another really key question to ask yourself is, what are the most frequent questions you're getting from prospects, from adult children, from your existing residents and your team members? Because that really starts to tell you where you might have some gaps and where you need to shore up some areas. Do you keep a list of those commonly asked questions and train your sales team? That would be another element of that. And of course, as Melissa just mentioned, when you're looking at your strategic plan and your roadmap, is there a financial benefit? Does it help the bottom line? Is a key consideration. And then as you kind of start to drill down, you have to start to think about alignment. There's been a lot of talk today and yesterday about alignment. And so when you start to evaluate partners or third parties that might be helping you, the reputation of that company, how do you know that you have a fit? There are a lot of providers, from low end to high end and everything in between. So, we really encourage you to think about doing some research. You can find quality measures on all of these organizations, places like cms.gov. Another key area, and Melissa touched on it, is that communication, that alignment. If care is happening in your building through a third party, you are still accountable for what's happening in your building. So how are you sharing information on that resident? How are you managing that continuum, knowing what's going on with the resident and where an HCBS provider might pick up and you leave off and vice versa? I think an obvious question to be asking yourself is, do I want to do this self-performed? Do I want to start my own home health business? Do I want to start my own hospice? Or am I going to work with a third party? Maybe you're doing one of those now and are thinking about making a change. So a good question to ask. And I think another thing to really think hard about is regulatory risk. That's a big topic in everything we do. And again, as I said before, if care is happening in your building, if hospice is there, you are still responsible for what's happening. So making sure you're aligned on what are our quality standards, how do we deliver care and services, and are they a fit?
So how has home and community-based services impacted the brand of your community? I think that we can all agree that we spend a lot of time, a lot of money, and a lot of energy really looking at our brands, especially in the CCRC space and senior living space. So if we're spending all the time and the money and the energy to make sure that we have a quality brand and a high reputation, wouldn't we want our partners to have the same thing? So how are we selecting our partners, and does it align with our brand? Are we really looking at what their reputation, what their core values are? Do they align with what our mission and vision are? Because those are really important things to take into consideration as well, not just for your brand, but for theirs. So how do you do that? Do they have a good reputation in the marketplace? Interviewing people that have had experience with them, whether it's strategic partners with your medical director, whether it's your own residents. Have residents had a very positive experience with family members or loved ones working with that home health, hospice, or private duty? Your residents are going to be the first ones that are sitting in your ED's office complaining if it is not the right fit for them. So you want to make sure that you have that alignment. And then do you utilize it for your referral sources? We have business development people in all of our communities for the most part, and can they piggyback with that strategic partner? Do you have usually medical directors, just as Justin was saying, can we leverage that and it impact our bottom line? Can we increase our revenue by tapping into our own sources that we already have? And then how has it negatively impacted? If you have a partner that doesn't provide the quality of care, maybe they had a good reputation, but you're not having meetings with them, you're not having training sessions with them to communicate your expectation when they're in your community, and the communication with your residents and their family members, it can be negative. And as well as Justin said, just the regulatory risk. If they're not following up what they have to do, whether it's signing in or vaccinations, whatever your regulations are tied to, you want to make sure that they're following it, because you don't want a negative survey to impact your brand or your healthcare just because you weren't in alignment on that.
So as we play out that thread a little bit that Melissa was just talking about, I think an obvious question to ask is, how can home and community-based services help or increase family and resident satisfaction? So assuming that you've got that person in your organization who helps manage that continuum, there's a conversation that probably happens almost every day, if not every week, at all of our communities. And that conversation goes something like this. Phone rings, night nurse is calling the adult child. Mrs. Jones, calling to let you know your mom fell, she's at the hospital. I don't know about you all, but there's probably about 27 questions that immediately would pop into my head if I was that adult child. So if you have that case management person in place, a lot of our communities, especially the new ones, even if they don't have skilled nursing, we add that care concierge because their job is to really pick up in those gaps and make sure that when a resident has a change, has an event, that we're in the middle of that and we're coordinating on that resident's and that family's behalf. So that conversation should go as a little something more like this. Mrs. Jones, this is the night nurse. I'm calling to let you know mom fell. She's on the way to the hospital. I'd also like to let you know that Melissa, our care manager, is on the way to the hospital. She's going to coordinate with the doctors. She's going to figure out what the treatment plan is. And then we'll have a slate of options for you for when we get mom home, what that looks like, and how we can support her to getting her back to her best level of independence.
So what are some of the best practices for integrating home and community-based services into your community? So again, we talked about feedback from trusted sources. I think that that's extremely important because every market's going to be different. What is a phenomenal organization in one market might not be the best because of local leadership in your market. So really tying into your residents, tying into the staff that have worked in this industry, and really doing your homework on that. Public information, if they are a Medicare certified agency, which most home health and hospices have to be, go online, look at their surveys, look at their percentages, look at the feedback and look at their reviews, because again, they're gonna tie to your brand, and what does that look like? And I think sometimes it's easy to get in the trap of having a social worker have somebody come and market to them, and they're friends, they love seeing that person, but are we really researching who we're referring to? Are we referring to Sally because Sally has phenomenal care? Are we referring to Sally because Sally's our friend? And I think that that's really important to look at because it will impact your community if you do a referral or a discharge from skilled nursing to a home health or a hospice or another company that doesn't have quality care. They're gonna bounce back to the hospital, it's gonna impact you. But if it's also in your own community, your residents are gonna let you know about it. So, case management, I know that that's something that Justin touched on as well. And yesterday, Mindy made a comment of, we talk about meetings and things, but are we really doing them? Are we doing a level of living meeting each week and each month to really review our residents that are at risk in every level of living? Because that can definitely impact not only your bottom line, it messes with your attrition and your bed management. So if you have independent living that have been declining and they really need assisted living, what does that look like? Are they on hospice? Have they been back and forth to the hospital? How many people are on home health right now? Managing those moves will help your bottom line, and your sales team will know what their availability is going to be in some of those levels of living. The last thing you want is for things to be a surprise. You'll have things come up here and there, but if you're really managing that information, you'll be able to do that. And I know a lot of people say, well, we have that meeting. Well, if you're not getting that information, I'm going to challenge you to rethink how you're having that meeting and the information that's coming out of that meeting, because that will really impact your bottom line.
I would also add, Melissa, that's a great point, but I would also add, who are you including in that meeting? If you have a preferred partner, are you integrating them into your meeting so that as a resident needs to make a change or needs another service, that information flows seamlessly as well?
I think another thing that people really don't talk about is what are the required trainings that are tied to your partners. So I think most people don't realize that hospice is a regulatory requirement that they do an annual training with every single one of their partners that they have communities in, and they have to document that. So Do you know if that's happening in your community? Have home healths come in and been trained to what your practices and your sign-in policies are and your after-hours policy if there's an emergency for them? Do you know if a resident had a fall or an emergency? What does that communication look like? And how are we setting the standard and requirements for communication? Because I think that that's really important. And then if you don't have a case management type role and you can make that work in your budget, it's very helpful. And that's what the consumer now is asking for. They're asking us to case manage their loved one or their parents or their spouse. Because again, when they move in, they expect that we are going to take care of all their needs. It's not just going to be a beautiful community to move into, but we are going to be responsible for as long as they live there. And then if you have a skilled nursing social worker that can help in any capacity that isn't helping, integrate them in that because they can start having some of those conversations to help you as well.
All right, so let's talk a little bit about this third party versus in-house. A lot of you here might have your own HCBS in-house. Some of you might go third party. There's some pros and cons to consider as you're reevaluating that strategy and thinking about how you want to approach it. I'm going to talk a little about third party, and then Melissa's going to take us through kind of the in-house approach to pros and cons. So obviously, if you go third party, it can be a really good benefit to your referral source growth. These companies have a lot of people on caseload. If you're a cultural and value fit with that other company, and you know you're delivering good care and you feel good about the services they're delivering, the natural inclination is that you're going to share residents and refer residents back and forth. And so that's a great way to grow some potential leads, particularly for your assisted living, as well as memory care, but even independent living. If someone's had an event, their life has changed, they might want to think about making that move to more of a all-inclusive solution. Staffing supplementation, we want to be careful here, but there can be more eyes on your residents, which is great. The key is making sure that care is coordinated, because if home health is coming into your community, say for a resident who's on wound care, it is still your responsibility to make sure that care is being delivered, and not just the home health job. But there can be a benefit to more eyes on that resident, especially if you're aligned on your quality standards. The other nice thing is the HCBS world is a very unique skill set. You add that expertise quickly and with limited to no cost. And so you don't have that expertise risk. There is the potential for reduced liability risk. Again, that alignment and communication is really key. I'm going to take a quick moment to talk about on Wednesday, we had an attorney from Hanson Bridget join us to talk a little bit about particularly assisted living and memory care risk. And marketing and salespeople, sorry, close your ears for a second, do a TikTok, whatever it is that y'all do with that stuff. But his advice to us, and he used an anecdote that involved home health. Resident was on wound care, staff, the community had basically delegated it to the home health. Wound advanced, sent to the hospital. Hospital called the state on the community because the wound had advanced and it hadn't been reported. And so that was probably a 7 to 10 figure lawsuit that company had to pay. So yes, while there is the potential for reduced liability, there's also potential for exposure and risk. However, one thing that he did say as he was closing, he really encouraged us to everybody look at your residency agreement, look at your resident handbook, look at your marketing material. And there's a 5-letter word that is a bad word that plaintiff attorneys love. And also, unfortunately, I've seen a lot of our material, and that word sometimes creeps in, and that word is insure. And not only is it a really yucky protein shake, but it's a word that can really get you in trouble because plaintiff's attorneys love it. Think about words like support. Think about words like growth. Think about words like assist. But insure is a word that we really need to excise from our vocabulary. On the con side, the third party, you really have to think about your environment. You've got new people coming into your building every day. That can be a challenge. Who's in the building? Do they have a background check? Do they have their vaccinations? All those elements that you have to think about. Staffing competition. You have other nurses coming into your community, you have other managers from other companies coming into your building. So the staffing world is cutthroat, and if you've got a great nurse or a great caregiver, guess what? They're gonna start recruiting them. So as you think about those third-party agreements, non-solicitation is a big key to that. There's no revenue share typically in a straight third party unless you're looking at a JV or something more complicated. And there can be some additional administrative burden as we've discussed.
So while Justin was speaking, I was checking on my team. I didn't see, forgot I'm part of marketing, that I didn't see any TikToks happening there. So I'm going to talk about in-house a little bit because I've done a little bit of both. I've done JVs where it's in-house or we've had our own, and then I've also done where it's a third party and we're partnering with senior communities. But in-house, it is an additional revenue source. If people look at the reimbursement for the hospice segment, I know Medicare's challenged with home health and the Medicare certified, but hospice has been one of the only organizations that they have not cut any funding. It has been increased every single year. So it is an additional revenue source. And many communities look at it as if we go in-house and we do it well, we can provide care to our own residents and we can also increase our bottom line. So there's a positive for that. Staff flexibility. You know, we hear about overtime and things like that, but what about the staff members? Maybe you don't have it in the budget for overtime and everything looks great for your staffing, but maybe you have a staff member that really needs extra overtime. Maybe they're sending a kid to college or something came up in their life. You have the staff flexibility for you to be able to have them pick up admissions for a hospice piece or admissions for home health or pick up a caseload on the weekend whenever they're not working. And it's by somebody that they trust and they know and they see in the community. So there is a loyalty piece and a quality and customer service aspect to it. Dual referral source. If you care for patients at home and it's in-house, that is a direct referral source to your community. So are you managing that? If you currently have one in-house and you have a community-based product, is your social worker talking to your community to say they really need to be moving into a community? Again, you may be having those meetings, but if you're not getting the right information out of it, you might want to look at that so that way you can evolve that process. And then again, it's a continuum of care. That's what our residents expect. And it just adds to the continuum that you have your own. You can manage the product, you can manage the people, and you can manage the mission and vision. Financial risk. So if someone does not have one in-house and they're looking at it, you need to see what kind of financial investment you want up front, because even though it's not brick and mortar like the developments for Greystone, there is a financial investment in getting Medicare certified or buying an existing license. But then also, I'm going to tie that to the regulatory challenges. I'm sure many of you have seen, you know, the OIG and CMS, they'll do raids and they do all these audits post-COVID, and that's always been part of the hospice space, but it's been increased now. So with those come fines and fees, and if you don't really have the expertise there, it can be, crippling to your organization financially. Management burdens, hiring a new team and making sure that you have the right people in the right management spaces that know what they're doing in that sector, because you can't have an administrator of, the skilled nursing side also be the administrator of the home health or hospice, but making sure that you've got the quality people in the right space. And then expertise risk. Sounds great every day to open an organization, to have a new revenue stream, but if you don't know how to do it and do it well, it can be a huge risk for you, not only for your referral sources, but your existing residents and for your financials.
All right, so as we wrap up, really kind of one last question to kind of tie into as we look forward to the future. What are communities going to look like? What are services going to look like in the next 10, 15, 20 years? So we've talked a lot about home and community-based services as it relates to healthcare. And so as an industry, we do a really good job of that reactive ability to respond to an issue. We've done that great for years, and that's healthcare. As you kind of move through that span to the preventative side, we've actually made great strides in educating residents, educating team members, educating families on what you can do to prevent issues. But as we listen to the presentations, what we all want to attract and what we all want to bring is that aspirational senior, the one who has taken good care of themselves. And so as we look at third-party services that we might want to think about adding in the future. I think an area that is primed for change in all of our communities is that lifestyle programming, whether you call it life enrichment or community life. The self-directed senior knows what they want, but they want support and help. With the proliferation of data and AI, they know what their risks are. They know what they want to do, but are we bringing the right third parties along to help them reach their goals and do what they want to do in retirement? So I think that's what we're going to see third-party services really expand. And as we look at redesigning our activities and lifestyles and community life programs, I think we're going to see a lot more need to integrate with those specialty services. So with that, thank you for your time. You're doing great.